Although overdose management and pharmacology has no specific section in the internal medicine boards, every year a handful of questions relating to this topic show up. They make excellent questions to make sure you understand acid-base, for example, osmolar gap, the management of the unconscious patient, and so forth. And so I think it's important. Now, I would not memorize obscure overdoses because that's just not going to show up on the internal medicine boards. They didn't even show up on the emergency medicine boards. I would, however, focus on a few of the general principles that will leave you in, I think, good position to answer any questions that pop up. First of all, a couple of questions about epidemiology. I used to update this slide every year, but I quit because it hasn't changed in the last decade. Every year to the Poison Control Centers of America, about 2 million overdoses are reported. And when you look at the numbers in general, 86% are intentional, or unintentional rather, are accidental. And the majority of those occur in children. Now, out of those 2 million exposures, it's important to remember two things. Number one is where they occur. And the vast majority occur in the home. And it's comforting to know that we're not poisoning too many people in the hospital setting. That's the first week of residency right there. But when you look at those 2 million fatalities, and the Poison Control Center, if you've ever called them, does an amazing job of pestering you for follow-up information regarding these patients. What you find is that there's a very small number of actual fatalities due to overdose, at least as reported to them. And when you look at the overdoses, and each year it's about 650, 700, something like that. When you look at those, really that's a fairly typical sort of presentation. Those are almost always adults, and those overdoses were intentional. So a much different group than the group that worried moms that call the Poison Control Centers. Every year, when we look at which groups account for the most deaths, when I first started, actually, 10 or 15 years ago in the emergency room, this was a little bit different. And in fact, tricyclics were a very common cause of death in the overdose setting. We don't hardly see that anymore at all. Analgesics, and essentially over-the-counter analgesics, Tylenol, acetaminophen, and aspirin account for the most deaths. This is for ingested toxins, however. If you look at toxin deaths in general, the number one killer is carbon monoxide. And being an ER physician, or I should say a past ER physician, and now an internist and preventist, I would be a little bit remiss if I didn't mention a word or two about alcohol. While it may not kill as many people as some of these other toxins, it's a huge cost on society. When you look at how it's involved in death, it's quite amazing. 40 or 50% of all drivers involved in fatal accidents are intoxicated. 50% of everybody who drowns is intoxicated. 40 or 50% of everybody who dies by a fall are intoxicated. About half the people who die in fires are intoxicated. 30% of the people who die by being struck by a car are intoxicated. And here's no surprise, about 80% of the people who don't hear a freight train sneak up on them are intoxicated. And I was amazed to find out at the FAA last month that 16% of all light airplane crashes are associated with significant alcohol intake. So that's a staggering number. In fact, in some busy emergency rooms, when I worked on the weekend shift, for example, maybe two-thirds to three-fourths of my patients were actually intoxicated. On the boards and in real life, don't miss the elderly patient who just kind of presents as a confused picture. I'll never forget the patient. I was referred to me from the endocrinology department for admission for DKA. And because she was fairly sick, we stopped her in the emergency room and performed some tests. She had some pulmonary edema. Her sugar was actually normal. She had no ketones, and she was aspirin toxic. Any unconscious patient or patient with an altered mental status, strange behavior, should be suspected of an overdose, and keep that in your differential as you go through the clinical questions on the boards. Now, this is a fairly typical scene for me when I used to work in the emergency room. A mother would bring in a bag full of this stuff from underneath the counter and say, "Johnny got into something, I'm not sure which of these it is." Now, this can be sort of a daunting task, but the more and more you realize, the more you know about toxicology, the more you realize you can help sort this out. And you can start by eliminating some of the things such as the hydrogen peroxide and the 3% concentration, not likely to harm the patient. Look at the baby. If the baby's awake and talking to you, the chance that they took a significant isopropyl alcohol overdose is unrealistic. And you can go down the list. My point is this: there are 3 or 4 syndromes or toxidromes that you absolutely should be able to recognize just based on the clinical scenario, because these will show up on the boards. The most common and a favorite one for them to ask about is the anticholinergic syndrome. The reason it's favorite from an internal medicine standpoint is that there are a lot of medications that we use on a daily basis that can cause this syndrome. Tricyclic antidepressants, antihistamines, some of the antipsychotics, some of the anti-Parkinson medications, and atropine. The syndrome, and there's a mnemonic for it, which I've never been much on mnemonics, but if you like a mnemonic, the mnemonics in the book about hot as a hare and blind as a bat and all this sort of stuff. But in general, the patients present with warm, flushed, dry skin. Their pupils are dilated. They often have urinary retention and decreased sweating and salivation. Worst case scenario, they have a significant altered mental status and, in fact, have seizures. And we used to deal with this all the time when I first started when dealing with tricyclic overdoses. The opposite of this syndrome is the cholinergic syndrome, and you will always be able to recognize this clinically because these are the people the ambulance personnel are in a hurry to get off their cart. The reason is that essentially if there's a body fluid, it's being produced and in an uncontrolled fashion. So the paramedics can hardly wait to dirty your linen and get on with their business. These patients are sweating, salivating. They oftentimes are incontinent of bowel and urine. They are tearing. And of course, like you would expect, they've got bradycardia, pinpoint pupils oftentimes, and an altered mental status. You don't see this very often. When you do, it's quite dramatic. I've taken care of a couple of people who in a suicide attempt have taken pesticides and things, and when you see the syndrome, it's quite dramatic. You should be able to recognize this, presented this clinical picture. What about opiates? We talk quite a bit about the classic triad. The classic triad absolutely must be recognized with pinpoint pupils, respiratory depression, and altered mental status. Remember also that pulmonary edema is a common problem with some types of, or some members of this family. Nausea and vomiting as well. Barbiturates are an interesting group. I've taken care of a number of barbiturate overdoses, and one of them was accidental. In fact, a patient had it was a medication refill error. The pharmacy had replaced his methylphenidate pills for his, what the heck did he have? Narcolepsy or some sleep disorder or something like that, with a long-acting barbiturate. And he kept getting more and more tired and would keep taking more and more of his Ritalin without any effect. And he came in essentially in a coma. Hyporeflexic, they're very hypotensive, and some of you practiced in the days when we used to use barbiturates a lot for dealing with status epilepticus. These patients are very hypothermic and areflexic. A lot is made about the blisters that will sometimes be seen with high-dose, with barbiturate overdoses, but that is in reality a rarity. So hyporeflexic coma associated with hypothermia, bradycardia, hypotension, think about barbiturates. Especially in a patient, perhaps if the boards gives you a hint that they've got a seizure disorder, for example, think about that. I tend to lump a lot of medications together under this particular heading, and I will lump together amphetamines, cocaine, caffeine, aminophylline, because they can look very similar on initial presentation. There is general CNS excitation and agitation, elevated blood pressure and pulse, of course, as you'd expect. In worst case scenario, there are seizures. Finally, substance withdrawal, which can look a lot like the sympathomimetic sort of picture. However, I will just point you to this right here. If there's a significant amount of abdominal pain, think about substance withdrawal. Otherwise, the syndromes can be pretty close. At a bare minimum, please be very comfortable with the cholinergic syndrome, the anticholinergic syndrome, the barbiturates, and the sympathomimetics. Now, if I had to do one blood test in the emergency room, it wouldn't be a drug screen. It would be a blood gas. Blood gas can actually help you diagnose carbon monoxide poisoning. I've had several cases of methemoglobinemia and this sort of thing, and you can actually get the answer right off the bat. In addition, it gives you the information enough to calculate the anion gap, which can be very, very helpful in looking for some particularly worrisome overdoses. I know that you've gone into acid-base data earlier with the critical care doctors. From an overdose standpoint, there are two situations in which you can actually get a decreased anion gap, and those are bromide and lithium. More importantly, however, an increased anion gap should have you hunting should have you hunting for certain overdoses, particularly the alcohols, methanol and ethylene glycol specifically. Salicylates, INH. A favorite question nowadays is on a patient who has exposure to INH, such as a member of the family is undergoing INH prophylaxis, and a youngster comes in and has intractable seizures and an increased anion gap. Think about the possibility of INH overdose. And another one that oftentimes is forgotten is that iron can cause an increased anion gap. Next is the osmolar gap, and the osmolar gap is important as well. I recall having to calculate an osmolar gap, I believe, when I took this test not all that long ago. This is the difference between the osmolarity as measured by the freezing point depression and the calculated osmolarity. Now, what do you think the chances of them giving you a question in which they specifically spell out the measured osmolarity? Why would they give that to you if they didn't expect you to be able to calculate out the osmolar gap? And in fact, they probably do. So your antenna should go up when you see a osmolarity presented to you. The osmolarity is 2 times the sodium plus the BUN divided by 2.8 and the glucose over 18. An osmolar gap is when the measured osmolarity that they give you is greater than the calculated osmolarity by 10. And there are certain substances in the overdose setting that you should think about. Basically, there are the alcohols, and we'll spend a minute on that in just a second, and some diuretics, which are less important from an overdose standpoint. These, however, are critical to recognize. We're going to take 1 second now to speak of the alcohols. And when I speak of the alcohols, I'm talking about this group right here. Ethyl alcohol, isopropyl alcohol, which is also known as rubbing alcohol, which was a favorite of some of my Saturday night regulars. Ethylene glycol and methanol, wood alcohol. Ethylene glycol, of course, was commonly an antifreeze. I don't know if it still is. I think they've gone to some alternate substance maybe. Anyway, ethylene glycol as well. All 4 of those alcohols produce an osmolar gap. This is a favorite area for questions. So all 4 of these will produce an osmolar gap. Methanol and ethylene glycol you can sort of lump together because you need to think about them together. They are both very, very dangerous in even small amounts for the most part, and essentially their treatment is the same. In the old days it was an alcohol drip. Nowadays there's a competitive binder that called something, I can't remember the name of it just yet, Actazol or something like that. Anyway, lump these 2 together. These often produce significant anion gap metabolic acidosis, and you'll see bicarbonate levels less than 10. In fact, you'll see them down around 2 or 3. It's quite dramatic when you see it. Now, the osmolar gap has you thinking about the alcohols. The high anion gap, the significant anion gap, has you thinking specifically about methanol and ethylene glycol, along with the clinical picture as well. To separate out those 2, remember ethylene glycol produces calcium oxalate crystals, and that'll help you separate those 2. So if they show you a picture of these crystals in the patient's urine, you'll know what they're getting at. Okay? Calcium oxalate crystals. So ethylene glycol and methanol can be thought of together. To separate the 2 of them, they'll probably show you a picture of calcium oxalate crystals. In the old days, we used to take the patient's urine and a Woods lamp and go into a dark closet in the emergency room and see if it would fluoresce, because one of the common places that a patient would get ethylene glycol was from drinking antifreeze. Fluorescein is put in the antifreeze to trace leaks that occur in the sewer system and illegal dumping and that sort of thing, but it would give us an advantage. Now, I can tell you the nurses tend to look at you a little strange when you steal the patient's urine sample and head off into a dark closet with it by yourself, but it will give you a hint about what's going on. Finally, rubbing alcohol is a little bit unique. It does produce an osmolar gap, but it generally doesn't produce a significant acidosis unless something else is occurring with the patient. And in fact, the patient has a significant amount of ketones. So recognizing the alcohols is not particularly difficult, nor is separating them. You can do all of this before you get the specific alcohol levels back, the volatile alcohol levels back. Isopropyl alcohol generally requires supportive care and not much more. I've had a number of patients intoxicated with that over the years. You know, when you walk by a downtown drugstore and you see rubbing alcohol piled up in a pyramid configuration with a sign that says 99 cents each, who do you think that's appealing to? Who's using rubbing alcohol anymore? Now we start to talk about a quantitative blood level, or now we talk about drug screens and drug levels and this sort of thing. And to be quite honest with you, this is about the order I approach this in. When you look at that list right there, there is one, and I would argue only one, overdose that scares me. Well, maybe two. There are two overdoses up there that scare me, that I can miss very easily on the clinical exam, and in which drug levels are extremely important. Which ones are they? Acetaminophen, absolutely, and I have seen more than one case of these patients end up in the hospital, didn't tell the emergency room or the other physicians that they had taken the overdose, and they presented as acute liver failure, and you've probably taken care of some of those in your residency. The other one that bothers me a little bit is iron, because iron can have a latent period. Iron overdose is not particularly common in adults, and I don't think it's an area that you get asked a lot of questions about. It's a lot more of a pediatric problem, but adults can overdose on iron. When I first started practicing, we approached everybody with a coma the same way. We gave them all D50, followed by 100 milligrams of thiamine to prevent the precipitation of Wernicke's encephalopathy, and 2 milligrams of naloxone. Actually, it was 0.04 milligrams in those days. And we should dismantle that myth right now. In general, empiric use of dextrose is no longer recommended. In the old days, we did that because we felt that a low blood sugar is something we didn't want to wait for laboratory confirmation. Now with AccuCheck readings that can be determined in a matter of minutes, that's no longer an issue. We do know, however, that several overdoses can cause hypoglycemia, besides obviously the diabetes medications. Ethanol, insulin, beta blockers, and salicylates all can lower the sugar, and so keep this in mind. Finally, the feeling that IV glucose given to patients who did not have low blood glucoses was harmless has fallen by the wayside, and in fact there are some good studies that suggest that patients who have other brain insults such as hypoxia, stroke, closed head injury are actually harmed by higher levels of glucose, and as such wait for laboratory confirmation. It should occur at the bedside with point of care testing. Naloxone is a derivative of oxymorphone. It's a competitive antagonist of the opiates. It has little or no agonist activity. You can give it many routes: IV, IM, sub-Q, endotracheal tube, a pinch between the cheek and gums. I don't know how you can give it all sorts of ways. It works quite well. Does everybody need it? No. And in fact, there was a great study out of UCLA looking at the EMS system in California, where there was right in downtown Los Angeles, when there's a relatively high amount of IV drug abuse compared to, for example, Minnesota. And the paramedics could predict right down the line who was going to respond to Narcan or naloxone. They could predict it by, they looked at three things. They looked at, first of all, everybody had to have an altered mental status. Number two is they looked at the pupils. Number three, they looked at the tattoos. Well, they didn't really look at the tattoos. They looked for signs of drug abuse. And in fact, they predicted every single responder to naloxone. So that you're not going to miss the opiate overdose patient. You'll recognize that clinically. Whoop. The care of the overdose patient falls into four broad groups: supportive care, decontamination, enhanced elimination, and finally an antidote. I will tell you right off the bat that antidotes are not particularly important for the vast majority of overdoses. And when we're talking about helping these people, because so many of them are not particularly lethal or even necessarily dangerous, good supportive care is oftentimes all you need. We don't want the cure to be worse than the disease, which was often the case when I first started, and we reflexively did gastric lavage on everybody. Those days are gone. Good supportive care, to my way of thinking, is generally just one thing and one thing only for these patients, and that's airway, airway, airway. Everything else is a little bit less important, but there are a few other things to consider, such as when to release the patient, how long to observe them, and what the surroundings that they will be going home to are. In general, however, good supportive care is airway. And one of the areas that questions are often asked about is, for example, the patient who comes in with an overdose of something that you think you'll be able to reverse, such as benzodiazepines, who theoretically you could use flumazenil or opiates where you have narcotics. What is the role of that versus protecting the airway? And I'll tell you that the standard answer is still the same. Airway A comes before everything else. You get control of the airway, you secure the airway if necessary, and that's the ABCs of patient care still come first before everything else. So don't put the cart before the horse or get too scientific, and just stick with the basics and you'll do all right with these questions. That's all I'm going to say about supportive care. Let's talk about preventing further absorption. Don't forget to decontaminate the skin. This is a patient who was exposed to anhydrous ammonia. And these patients can come in, and although they're not particularly complaining of much, if you forget to take off the boots and look at the pool of anhydrous ammonia sitting in their boots, by the time they get up to the floor, what you see is tendons hanging out. It doesn't take that long. So remember good supportive care. Irrigation with copious amounts of water for most substances. There are a few that water is contraindicated for. White phosphorus, for example. I don't think you'd be asked a question like that on the boards for internal medicine. You might for emergency medicine. You certainly would for toxicology boards or something like that. But in general, copious irrigation with lots of water. Some substances are absorbed fairly well through the skin, and you need to remember that. Gastrointestinal decontamination remains one of those areas in the overdose managements that is still mildly controversial. We have lots of ways we can empty the stomach and perform gastric decontamination. We can induce emesis, we can do gastric lavage, we can give activated charcoal, and I'll talk specifically about these three in just a second. There are two other techniques that we have that are actually growing somewhat in popularity. Multiple dose activated charcoal. In essence, this is giving activated charcoal again over a 2 or 3 hour period and repeating these doses as necessary, specifically for those substances which are known to undergo enterohepatic circulation. Classic examples would be theophylline, tricyclics. I think some of the barbiturates do that. The problem with multiple dose activated charcoal is, as you might expect, it greatly increases the risk of complications, at least from a GI standpoint, including ileus, impaction, bowel obstruction, and at least 2 studies have shown that it increases aspiration. I think if this was going to show up as a question, because this is relatively controversial, it would probably show up as which drugs undergo intrahepatic circulation and therefore might be candidates for this. I don't think you would have to pick this treatment option. Whole ball irrigation includes placing an NG tube, or usually an NG tube, and putting through the intestinal tract something or go lightly or sort of balanced electrolyte solutions to try to the passage of growing in popularity, especially in the pediatric literature, where iron overdose is a particularly dangerous overdose. Charcoal doesn't bind iron very well. This makes it a kind of a perfect setting for this. This has limited utility in adults. I don't think you would be asked a question for this. If you did, it would show up in terms of which substances are not well bound to charcoal, and we'll address that in just 1 second. What about Ipecac? This has been the greatest myth perpetrated on humanity, as best as I can tell. Every mother was convinced that when they left the hospital with a new baby, they had to have this and put it in the drawer, and it's absolutely, utterly ridiculous. Ipecac is both a locally acting emetic as well as a centrally acting mimetic. It acts in the chemotactic trigger zone of the medulla. Also is a local irritant in the stomach. A single dose will produce vomiting in about 20 minutes in roughly 75 or 80% of the people. Occasionally a second dose is needed. The problem, there are a lot of problems besides my slides. The problems are many. The biggest one, however, is it's never been proven. All right? If you take medical students under ideal circumstances and have them ingest radiolabeled compounds, immediately give them the right dosage of Ipecac, water like it's supposed to be done, and then collect what they vomit, how much do you think they bring back? Maybe a third of what they ingested. Okay? And that's under ideal circumstances. So we're kidding ourselves by giving patients this that showed up in the emergency room an hour or 2 after their ingestion. It may occasionally be recommended from time to time by a poison control center if a mom has a child and they're a long ways away from an emergency room, but that's pretty rare. Certainly never give it if it's been for non-toxic ingestions. You know, the baby took 3 erythromycins or mom's birth control pills or whatever it is. You know, that's not indicated. Caustic ingestions, of course, we don't want that stuff coming back up. Same thing with hydrocarbons, that we're going to have enough trouble with aspiration-type pneumonias from those substances anyway. Less than 6 months, the airway protective mechanisms are not well developed, so we don't give it to those patients. Don't give it to patients who are likely to cause seizures or develop a decreased level of consciousness. Boy, you hate to give this stuff or have a paramedic give this stuff in the field in someone who took a tricyclic overdose, and then what you have is a patient who has rapidly gone downhill over 10 minutes, is unconscious or having a seizure in your emergency room, and has already wants to throw up and has been given Ipecac, and it's a terrible, terrible situation. Many complications have been reported after giving Ipecac, including prolonged nausea and vomiting, which slows down your ability to give activated charcoal. Mallory-Weiss tears. In the old days, when we used to give it to the elderly, we would occasionally induce an intracerebral hemorrhage, which is not particularly good. Reports of gastric rupture in children. And finally, it delays what may be the gold standard of treatment today, which is charcoal. What about gastric lavage? On the top here, you see the largest, or you see a large, I think this was a 16 French nasogastric tube, and here's a 38 French Edlich tube. This is the one I used to prefer. It's very firm, easy to pass. It was not a closed system. It was an open system. Thus, you were exposed to blood and body fluids. And in the old days, you did it barehanded, but in the last few years, they've gotten kind of sensitive about this issue. And they make you wear goggles and gloves and gowns. You pass that in the conscious patient. It's actually very easy to pass. You put the patient on the left lateral decubitus position. If they are cooperative, I will use a numbing spray in the back of the throat and go ahead and tell them close their eyes and swallow, 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 and it goes right down. If they are combative, I don't give them the benefit of the spray. We tie them down and we introduce it rather quickly. Now, there are a lot of complications from it, and remember, most overdoses aren't going to kill you anyway, and so we have to be a little bit careful. The use of gastric lavage has dropped off dramatically in the past decade. It doesn't mean there's not a place for it. And I believe in the year 2000 there is still a place for it, although the classifications of when to use it have certainly been narrowed. Patients need to show up relatively quickly after taking their overdose, within an hour. And there are studies from emergency rooms around the country that show that that's probably a minority, that's a significant minority of patients who show up that quickly. Make sure they've taken something potentially toxic. Tricyclics, aspirin, something like that. Make sure that they're not going to have seizures or CNS depression in the time it takes you to do the gastric lavage. Think of it especially for substances that are dangerous, have been taken recently, and are not particularly well bound to charcoal, and I'll give you that list in just a second. Don't give it in caustic ingestions. Remember, 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 the airway care comes first, and if there's any chance that there's going to be a problem, then an endotracheal tube cuffed for adults needs to be in place. The complications, and I can truthfully say I've caused every one of these. Aspiration, and not uncommon. Cardiac arrhythmias, frequently the patients will Brady down, and can develop some rather long and uncomfortable, at least uncomfortable for the doctor, pauses. They can also enter a supraventricular tachycardia. So I've seen all of those. I haven't precipitated ventricular tachycardia yet, but there's still time. Cases of esophageal perforation have been reported. I have not done that personally. However, I did put down an Edlich tube one time that wouldn't come back. I couldn't get the doggone thing back out. When I finally did, it came back out. It had doubled back and twisted around itself. Yeah, the patient did just fine. But I actually had to have my foot up on the bed to get the doggone thing back out again. I have put it down the trachea. Now, it's not a big deal if you put an Edlich tube down the trachea, unless you don't recognize it, and dump down 2 liters of saline and some charcoal. Then you do have a big problem. Finally, in a busy emergency room, it's very time-consuming. Even under skilled hands, from start to finish, it probably takes 45 minutes, and we don't have that kind of time anymore. So activated charcoal, with or without a cathartic, has grown to be the essentially the treatment of choice for most overdoses now. It can work in any ingested poison. In general, we don't give it for caustic ingestions, especially if we plan to do an EGD to gauge the depth of the mucosal burns. If the patient has an ileus or pre-existing bowel obstruction, but I can't imagine who that would be exactly. Complication rate from a single dose of activated charcoal is pretty small. So after beer, after Brussels sprouts, after broccoli, After every meal, it's charcoal plus. This is being actually touted as a general digestive aid. I haven't tried it yet. Most of the patients will willingly drink it. It's 1 gram per kilogram. We'll try to mix it with things, but it's still, is like drinking a ground up charcoal briquette. Am I doing something wrong here? Anyway, so it's going to be the treatment of choice for most overdoses. The patient has to be conscious and not likely to go downhill, a dangerous overdose, but it's the treatment of choice, I think, now for most overdoses. Activated charcoal, however, does not bind certain substances, and this list you should remember. First of all, it's the acid and alkali, so we're not going to be given in that situation anyway. The alcohols it doesn't work particularly well for, and some of the metals. And so when presented with one of these overdoses, some of these are very life-threatening. If the patients show up early enough, then you ought to think about gastric lavage for those. Okay? And the trends over the past decade continue to show a decreased usage of Ipecac and ever-increasing usage of activated charcoal, at least as reported to the poison control centers. All right, so that's preventing further absorption. What about enhancing elimination? Well, we need to talk a little bit about pharmacokinetics, and this is where an internist and ER doctor gets out on thin ice, but this might show up as a question, so we'll hit it. I'll show you where those questions might come from. First order elimination is kind of how the kidneys handle substances. A constant fraction of the drug is eliminated per unit time. The higher the plasma level, the greater amount of drug eliminated per unit of time. After 5 or 6 half-lives, as you're all aware, no significant drug is generally around. Most drugs are excreted via this route in their therapeutic ranges. Zero-order kinetics, on the other hand, is kind of how the liver handles substances. In this case, a constant amount of drug is eliminated per unit time. Drugs which are metabolized in the liver often involve enzymes which are saturable, have a saturation point. After that point is reached, plasma levels can rise dramatically. The classic example is the 82-year-old female who takes 4 aspirin a day for arthritis, is feeling poor, has decreased PO intake and aches and pains, and so it goes from 4 to 6 aspirin. Not a huge jump in her mind, may not even mention it to the doctor, and then comes in aspirin toxic. And I've seen that many times. Alcohol is also an example of a substance that involves saturation or enzymes that are saturable. The problem is that some medications go from first order to zero order kinetics, and this is a list that you probably should remember. The biggest are salicylates, phenytoin and theophylline. They switch from first order to zero order kinetics, and therefore a small change in dosage can make a big change in plasma levels. Salicylates, phenytoin and theophylline, the big 3. Now I want to talk just a little bit about volume of distribution. This will show up on your test. It shows up in different ways, perhaps calculating an additional drug dose for a patient on Dilantin, or trying to figure out what the plasma levels may be. So this does show up from time to time on the boards. In fact, it showed up for me, come to think of it. Volume of distribution is not a real volume, it's a hypothetical volume. That is the volume that would be required to dissolve the total amount of drug at the same concentration as that found in the blood. So it's a theoretical volume. If the volume of distribution is small, and by small we use a cutoff roughly of 1, if the volume of distribution is small, less than 1, then a large amount of the drug seems to stay in the blood compartment. If it's large, i.e. greater than 1, most of the drugs are distributed in tissues outside the blood. Tricyclic antidepressants, for example, can have huge volumes of distribution. Not only are they greater than 1, they can be 20, 30, 40, maybe more. And these are given actually in the PDR. If you hunt and peck hard enough, you'll find the actual numbers. You can use it to predict serum levels as well, and you can also use it to decide if the drug may be a candidate for hemodialysis. How do you calculate out the volume of distribution? Well, it's the amount of drug ingested over the concentration of the drug in plasma. So when you look in the PDR, volume of distribution is given as liters per kilogram times the body weight in kilograms. And if you look at this, even if you forget the equation, if they give you 2 out of 3 of these, and I think in the book I've shown you how to work an example of this, if they give you the patient's weight and the volume of distribution, you can figure out the amount of drug ingestion. They'll give you 2 out of the 3 variables, and as long as you're careful about keeping the units correct and remembering that volume of distribution is measured in liters per kilogram, you can usually go ahead and deduce the rest of the equation, even if you've forgotten the equation. So just like it was in high school mathematics, be mindful of your units and you'll be able to remember the equation. Volume of distribution in liters per kilogram. What about enhanced excretion? Step number 3 in the treatment of the overdose patient. Well, we have 4 things we can do. We have forced diuresis, we can alter the urine pH, we can do dialysis, and we can do hemoperfusion. Forced diuresis is not a major factor for most drugs. The very things that make drugs desirable from a patient standpoint, i.e. once-a-day dosing, etc., make them not particularly amenable to increased elimination via forced diuresis. Drugs with a high volume of distribution, again greater than 1, or a high degree of protein binding, are not effectively eliminated by diuresis. What about altering the urine pH? For ingestions of barbiturates, salicylates, INH, and perhaps lithium, alkalinization of the urine does seem to increase the elimination of the drug. In the case of aspirin, for example, salicylates. In the case of salicylates, if you alkalinize a patient's urine, you can increase the urinary excretion of aspirin about 300-fold. How do you do it? Well, I usually put 1 or 2 amps of sodium bicarbonate in a liter of half normal saline to try to keep the salt down, and go ahead and run that, and then you can monitor the urinary pH if you want. This is an example of how not to make a slide, but I didn't want to forget anything. Hemodialysis has a very limited application in drug overdose, and actually for substances to be amenable to hemodialysis, they have to have small volumes of distribution, be relatively small molecules, have limited lipid and protein binding, and that really isn't a lot of medications. There are a lot of times we wish hemodialysis would help us, especially in some life-threatening overdoses, but in fact the list of medications that hemodialysis helps in is pretty small, and it's right here. The 2 alcohols are amenable to hemodialysis, and that's important because they can be life-threatening overdoses. Lithium and salicylates, certainly, it's very nice in salicylates because it can help to correct the hyperkalemia that you'll see and some of the other metabolic derangements associated with salicylate overdoses. Bromide, and there are from time to time isolated case reports of hemodialysis working in some other settings, life-threatening Benadryl overdoses and this sort of thing, but those are isolated case reports. This is pretty much the standard accepted list. More importantly, and perhaps the thing to remember, is which substances doesn't it work for. And on this list are some things we wish it did. Tricyclic antidepressants, most antihistamine overdoses. The benzos, although we now have an antidote for benzodiazepines. Digitalis, phenothiazines, opiates, ethylchlorovinyl, which if you work in the VA system apparently is still used a fair bit. We don't use that much here in the Midwest, though. This is the list, and believe me, it would be nice, it would have been great to have something that would have worked for life-threatening tricyclic overdoses. I still remember the 18 and 19-year-old patients that I had that came in thinking they were going to do just fine because they got in relatively early after taking a tricyclic overdose, only to watch them go downhill and die in a matter of 1 or 2 hours. That was very frustrating in the first parts of my career. Anyway, hemodialysis does not work for many substances. What about hemoperfusion? In hemoperfusion, we take the blood out of the body, put it through an extracorporeal circuit, which actually has a cartridge containing charcoal or carbon or some other absorbent. The factors that limit toxin removal in hemodialysis are not as important in hemoperfusion. The major rate-limiting factors are the affinity of the absorbent for the toxin and the rate of the blood flow through the circuits. So basically, it's how much blood can you get through the system and how sticky is whatever the overdose is to charcoal. Those are the things that limit it. Think about it in cases of a barbiturate overdose, certainly with the long-acting barbiturates, ethylchlorovinyl, dilantin, and theophylline. Now, don't base your decision, and this is an important point, don't base your decision for hemodialysis or hemoperfusion on an isolated drug level. Always make that decision based on the clinical picture. Okay? For example, a patient with theophylline overdose who comes in, they can have radically different blood levels and response to those blood levels depending on if they've been on theophylline for a long time or not, depending if it was short-acting theophylline or long-acting theophylline, and the list goes on and on and on. So the blood levels can sometimes not be particularly helpful. Look at the patient. If you get a patient who was treated appropriately, was given gastric lavage, and 3 or 4 hours later has continued to go downhill, maybe perhaps have a seizure, multifocal atrial tachycardia or other dysrhythmia, does it matter what that repeat blood level shows? That's a patient where we need to do something more. Okay? In that case would be hemoperfusion. Same thing with aspirin toxicity and hemodialysis. The vast majority of aspirin overdoses do not require hemodialysis. And we don't base the decision to do hemodialysis in aspirin overdose on any particular drug level, but we use the clinical assessment. We use perhaps the potassium levels, glucose levels, acid-base status. We use all these things together to decide about which patients are going to be candidates for hemodialysis. So don't hang your hat on an isolated drug level in deciding who needs hemodialysis or hemoperfusion. Of course, if the substance that the patient has ingested is not amenable to either of those two, it's an easy decision. So hemoperfusion is indicated in some cases of barbiturates, dilantin and theophylline type medications. It is not without risk. It decreases the platelets. Bleeding complications can occur. Hypotension is commonly seen. And so there are a few. Remember that the carbon doesn't just bind to whatever the patient took. It binds to a whole bunch of stuff in the blood. And some of those things, you'd rather keep in the patient if you could, like clotting factors. Okay. Finally, and this is about the order to approach this in, are the antidotes. And I will tell you this. There's a more updated list in your book, actually. This slide is a little bit old now. In terms of antidotes, I would not spend any time memorizing the dosage of any antidote. I can't imagine you being asked a dosage. I think what you need to do is decide when the antidote is appropriate. All right? And remember specifically, for example, in acetaminophen overdose, that you can miss that. And there is a nice window of opportunity to go ahead and make that up with N-acetylcysteine. I would not spend any time memorizing overdoses of a rare type such as thallium and this sort of stuff. Concentrate on the big ones. Concentrate on the medications that have significant internal medicine ramifications such as theophylline, dilantin, aspirin, Tylenol, and I would probably leave it at that.
Question number 1. A 16-year-old female is brought to the emergency department 30 minutes after taking an observed overdose of approximately 30 extra strength 500 milligram aspirin tablets. She has a normal mental status and is refusing any treatment. Vital signs include blood pressure 100/70, pulse 120, respirations 36, and temperature 37.6. You should, 1, perform only supportive measures until you can reach a parent or legal guardian. 2, obtain an emergency psychiatry consult to determine the ability of the patient to understand the potential consequence of her refusing treatment. 3, give the patient activated charcoal orally and start an intravenous line that includes 50 milliequivalents of sodium bicarbonate per liter in order to alkalinize the patient's urine. 4, induce vomiting with 30 cc's of syrup of ipecac and start an intravenous line that includes 50 milliequivalents of sodium bicarbonate per liter. 5, place the patient in the left lateral decubitus position and perform gastric lavage with a large bore oral gastric tube, followed by activated charcoal and a dose of 1 gram per kilogram body weight. Start an intravenous line that includes 50 milliequivalent sodium bicarbonate per liter. The correct response is number 5. Use a large bore oral gastric tube, use charcoal and sodium bicarbonate. Question number 2. In the setting of acute overdose, a quantitative drug level is important for determining treatment in which overdose? 1, acetaminophen. 2, cyclic antidepressants. 3, digitalis. 4, opiates. 5, all of the above. And number 1 is correct, acetaminophen. Question number 3. Hemodialysis is always indicated in overdoses of 1, aspirin, 2, cyclic antidepressants, 3, phenothiazines, 4, theophylline, 5, none of the above. Number 5 is correct, none of the above. Question number 4. Which category of ingested overdose accounts for the most deaths each year? 1. Over-the-counter analgesics. 2. Over-the-counter antihistamines. 3. Cyclic antidepressants. 4. Opiates. 5. Ethanol and other alcohols. Number 1 is correct. Over-the-counter analgesics.
Ethanol and the other alcohols are involved in a lot of traumatic deaths, as I alluded to, but in and of themselves, in the overdose setting, aren't the sole cause. Acetaminophen and aspirin, year in and year out, accounts for the most common, or the largest number, rather.
Question number 5. A 50-year-old male is brought to the emergency department approximately 2 hours after taking a significant overdose of diphenhydramine. You would expect all of the following signs on physical exam except 1. Tachycardia, 2. Hypertension, 3. Meiosis, 4. Dry flushed and warm skin, 5. Urinary retention. Number 3 is correct, meiosis. Question number 6. A 60-year-old male has been admitted to the ICU following treatment for an overdose of a long-acting theophylline preparation. He was treated with gastric lavage and activated charcoal approximately 4 hours earlier while still in the emergency room. Initial laboratory evaluation included a normal CBC glucose electrolyte panel and EKG. A drug screen was negative except for a theophylline level that was slightly elevated at 26, therapeutic levels 10 to 20. You are called because the patient has just suffered a generalized tonic-clonic seizure lasting approximately 4 minutes. The ICU staff administered 5 milligrams of Valium per protocol. The patient is currently post-ictal and vital signs are blood pressure 100/60, pulse 140 and irregularly irregular, respirations 12. You should 1. Obtain an emergency CAT scan to rule out intracerebral hemorrhage. 2. Recheck a theophylline level as well as electrolyte panel to determine further therapy. 3. Pass a nasogastric tube and begin pulse charcoal therapy. 4. Make arrangements for emergency hemoperfusion. 5. Make arrangements for emergency hemodialysis. And number 4 is correct. Make arrangements for emergency hemoperfusion. Question number 7. All of the following would be expected to cause a high anion gap metabolic acidosis in the overdose setting except 1. Iron, 2. Ethylene glycol, 3. Isopropyl alcohol, 4. Ethanol, 5. Aspirin. Number 3 is correct, isopropyl alcohol.
Yeah. Remember that iron does cause a high anion gap metabolic acidosis. Isopropyl alcohol, rubbing alcohol, will give you a ketosis without significant acidosis. That's how it's separated from the other alcohols. I neglected to mention that ethanol, although most of you got that right, will also cause a high anion gap metabolic acidosis, and it's got to do with a number of mechanisms. It's generally not to the degree that we see with methanol or ethylene glycol.
Question number 8. A 19-year-old male is brought to the emergency department by EMS personnel. He was found in an alley behind a local bar. Drug paraphernalia as well as an empty prescription bottle for codeine were found on his person. Paramedics found the patient unconscious and placed him on a long backboard and cervical spine precautions. An intravenous line was started and the airway was managed with suction and bag valve mask. You note the patient to be unconscious with no response to painful stimuli. Vital signs, blood pressure 90/60, pulse 120, respirations 20, assisted. You note pinpoint pupils. You should 1. Give 2 milligram naloxone via the intravenous line. 2. Give 0.04 milligram naloxone via the intravenous line. 3, secure the airway by endotracheal intubation using inline cervical stabilization. 4, check the patient's glucose level and give 50 cc's of D50 if less than 100 milligrams per deciliter. 5, perform gastric lavage with a large bore orogastric tube. And number 3 is correct, secure the airway with endotracheal intubation. Question number 9. Which of the following statements regarding fatal overdoses is true? 1, most cases of fatal overdose are accidental and occur in the extremes of age, that is, the very young and the very old. 2, cyclic antidepressants account for more fatal overdoses than any other class of medication. 3, most fatal overdoses occur in the workplace. 4, most fatal overdoses occur in adults and are intentional. 5, approximately 10% of all overdoses reported to the American Association of Poison Control Centers are fatal. And number 4 is correct. Most fatal overdoses occur in adults and are intentional.
Most cases reported to the Poison Control Center, 2 million, occur in kids and are accidental. Those, however, are not the fatal